Okay, everybody, welcome back. So we're now on Module 5.
Wow.
It seems like we're moving along here pretty quick. I want you guys to, who are watching this, to buckle in, because I think Module 5 is kind of the meatiest. It's got a lot in there. There's a lot of discussion about how substances affect the body, and a lot of good information that's going to help you guys be good clinicians about making decisions about particularly who can go to sobering centers versus who needs to come to an emergency department for care.
For sure, and I think that's the key, right? That's the reason for this discussion, is because this is not an easy decision.
It's not.
But we also don't want you to be afraid to make a decision.
That's right.
Right, so equipping you with the knowledge and the skills and the abilities that you need to make the right decision. Well, hopefully get here with this, but of course you're going to come up with questions, and we hope that this is a good opportunity for you to ask those questions either of us or of your department's clinical leaders. And
door's always open for questions as they come up. So let's just step through the learning objectives for this module. So again, this is substance use and alcohol use under triage to alternate destination. So first off, we're going to understand the impact of substance use and abuse on our community at large. We're going to talk about what it's like to live with an addiction and some of the stigma that is associated with that. Common theme through most of our modules.
Stigma all day.
Stigma. So I think for us to start to speak the same language and to start to understand how substance use disorder, it's a disease, just like if you have heart disease or if you have asthma. To kind of treat it in that way and approach it in that way can certainly be helpful for all of us as clinicians. We're going to understand the difference between mental health disorders, intoxication, and medical emergencies. That's kind of sounds like the rubber hitting the road right there.
Yeah.
And discuss the common signs and symptoms of each. We're going to talk about discussing how to assess and to treat patients who have substance use disorder, and how to stabilize intoxicated patients as well. And then we're going to end up, just like with the other modules, with a case presentation.
Okay. Let's do it.
Here we go. All right, so just some kind of facts that I think frame our discussion here today. 15.4% of American adults have a substance use disorder. You know, if you just think about that, like you put 10 people out on just randomly off the street, 1 to 2 of those people are going to have a substance use disorder. That's a staggering number. 11.2% of all American adults have an alcohol use disorder. It just kind of frames the discussion about how many potential patients are out on the street, how many people that are engaging with 911 could potentially use this type of a resource of going to a sobering center. And the bottom line here is everyone knows somebody who struggles with either substances or alcohol. Yeah. I think that's true. All right, so some definitions. So substance use disorder. So that is a medical condition. Mm-hmm. So start off with the words that we all need to say is that this is a medical condition where an individual continues using a substance despite its negative consequences. So you're using and you become dependent on it, and then that use starts to impact your daily life, whether that's relationships, your ability to function in society, to be working, to providing for your family. That's when a substance use becomes a disorder, and it's truly causing that kind of downward slide in your functional ability. And with that said, so what's the definition for an alcohol use disorder? Let's say the words together. It's a medical condition,
right, Yeah, and if you think about like drug overdose compared to like ischemic heart disease. So this is more than just having a heart attack, right? This is also congestive heart failure. These are all the various cardiac diseases. So drug overdose outpaces ischemic heart disease 2 to 1.
That's right.
Which is kind of incredible. And we talked about suicide. I mean, drug overdoses outpace suicide 4 to 1.
That's right. And alcohol, even alcohol-related deaths outpace suicide, which is a very common, unfortunate reason for people to pass away. So mental illness in the American population, so aged 18 and over. So among those with a substance use disorder, 4 in 9 of those patients struggled with illicit drugs. 7 in 10 of those patients struggled with alcohol use, and 2 in 13 struggled with both. So you can kind of start to see that there's a very significant overlap between concurrently using things like methamphetamine, cocaine, and those types of street drugs, and alcohol use.
And some of these folks we talked about earlier use also because it quiets the other storm that's going on in them, with depression and things like that. So
some staggering statistics. So 38.7 million Americans 18 years of age and over struggle with a substance use disorder. 52.9 million Americans aged 18 and over struggle with a mental health illness. And the cross-section of those two, 17 million people in the United States aged 18 and over that have both substance use and mental health disorders.
Wow.
So it's just a crushing number, and it just highlights the fact that you're gonna encounter these people coming at you through the 911 system. So kind of even break this down further, and it's even gets to the point where you can talk about age 12 and up. So like the incidence of substance use disorder down into adolescence, high school age is
even younger than
significant.
that, right? High school, middle school, like we're seeing drugs and alcohol all the way down. Like, I don't know about, I mean, you grew up in Canada, I grew up in the US. I don't know what the Canadian high schools are like, but I don't feel like we saw a lot of drug use in high schools and middle schools when I was young. I know that was a long time ago, but it still doesn't mean that but alcohol use was there.
It was certainly there. I think it's certainly hidden, but I think that the incidence has exploded.
Yeah,
just exploded. So the staggering statistics from 2020. So of patients 12 and older that have alcohol use disorder, there's 28 million.
It's 1 in 10.
12 and older that have a use disorder, alcohol use disorder. It's staggering numbers.
Statistically, I used to coach baseball, so statistically on my team that I would coach baseball, statistically at least one kid on that team that I was coaching, I was traveling with when my kids were 12, one of them
could have an alcohol use disorder.
That's just frightening.
So there's some other statistics that came out of 2020. So illicit drug use within the year 2020 among people aged 12 and older. So 18% of them had marijuana use in their history. Other psychedelic drugs, 5.8%. All down, even cocaine and methamphetamine use being prevalent in that age group. Just a point on marijuana. So marijuana today is not what it used to be. So back decades ago, the active components in marijuana could be measured in the 1 to 5% range. But now we're 30-40% potency marijuana, which is leading to all kinds of other health conditions and reasons for people to be coming to see us in the ED.
Like cyclical vomiting wasn't really a thing.
That's right.
Until it started to get unmasked when it got legalized and you saw a whole bunch of people use it. And even when someone comes in who's using marijuana and they have this cyclical vomiting, they just don't believe it. It's like, no, it's something else. It's food poisoning.
Right. Yeah. But it's not. It's your pot.
It's your pot.
back of the EMSA published their commission report in December of just last year, 2023, and they talked about kind of coming forward with all of the numbers coming out of the COVID pandemic on what are the deadliest events in U.S. history. So the number one deadliest event, COVID-19. Mm-hmm. So the estimates are over 1.1 million Americans lost their lives directly due to COVID viral illness. To put that into context, the second most deadly event in U.S. history, the Civil War, 750,000 people died. The Spanish flu of 1918, 675,000 patients died.
Wiped out entire cities.
Entire cities. But then close behind the Spanish flu of 1918 is the opioid epidemic, just from the years from the turn of the century 2000 to 2021, so over 600,000 deaths. And you can just imagine, that's across all age groups, across all demographics, across all socioeconomic status, just an incredible number of people who lost their lives because of opiates. 2022, that number shoots up, the opioid deaths. So in 2022 alone, over 100,000 opioid deaths in the United States. Mm-hmm. Kind of highlights the fact that all of the work that's being done now with the opioid settlements, where litigation against the manufacturers of the substances that people were using, but it's just an incredible number of people who have died, and it just highlights the fact that we all need to be aware of opiates that are on the street, fentanyl that's out there, and other substances that we need to be looking for.
Meth is laced with fentanyl. Like, all the drugs that are out there are laced with fentanyl, and you'll see that coming up. There's actually a sign that I saw hanging in San Francisco General's door. In their ambulance bay doors, you walk into San Francisco General, hanging right there on the door, it says, "Your meth is laced with fentanyl." Mm-hmm. And the reason why is because the addictive potential of fentanyl was what causes the physiologic drive to drive them back more and more. But I wanted to make a point is that you implemented a policy where we had leave behind naloxone, mm-hmm. right? And so leave behind naloxone is now part of our county and part of several counties around. But I think of leave behind naloxone as the AED of the 2020s, right? You had AEDs that came out, and we did CPR, and we realized AEDs save lives. Well, now we have leave behind naloxone. It's like the new AED of the 2020s.
It's protective and saves lives. Absolutely. So this is another statistic that I was just floored by when I read this. So the number of people that were dying from opioid overdoses was the equivalent of 2 737 jets crashing every day. That's
just mind-blowing. Right,
and imagine what the response would be if we had 2 jets falling out of the sky every day. But again, these are all more or less hidden, like people out in disparate communities all across the United States, and you just can't put your arms around just the staggering number of people who lost their life.
Right.
So we have just some more data here that shows the drug involved overdose deaths, kind of this steady rise in the number of deaths. So back in 1999, there was about 20,000 per year. But again, just to highlight the point, in 2021, over 100,000 people dying per year, just in the staggering growth of the use of opioids in our population.
And guys are outpacing women.
Exactly. And to your point, so the question about why is there more overdose deaths, and that's that the fentanyl is stronger. Yeah. So back in the 60s, 70s, 80s, there was heroin use. There were overdoses from there, but the tiny amount of fentanyl that is needed to kill somebody is
fits on a pinhead. It actually fits on a pinhead, right?
Right.
So I've seen it on pictures of a penny where it's just as barely touching Lincoln's head. But the other thing about it is it, like you said, it is in everything that is out there. And the funny thing is that you ask people and they say, "No, I didn't use fentanyl."
Right. Right.
They have no idea that it's actually in it.
Right. So that methamphetamine that somebody uses that normally has a particular effect causes them to be maybe psychotic or up, and all of a sudden they're respiratory depressed and they're down. It's because there's fentanyl hidden in it.
And then there's also, we haven't talked about, we won't hit on, like xylazine.
Right.
Right. So horse tranquilizer, xylazine, has been found in the East Coast more than in the West Coast, but xylazine is not reversible by naloxone, and it is leading to a lot of deaths as well because it's mixed with the methamphetamine and the fentanyl along with it.
But there's good news, and the good news is that there are EMS treatments for opioid use or opioid abuse.
Yeah.
So one of the things that we like to talk about is how well are our EMS interventions in kind of helping people not go down the road and have a mortality event. How often can we step in as an EMS provider to keep that person alive and to keep that person well? So EMS interacts with patients during a high-risk event. So 1 year mortality from a heart attack, acute myocardial infarction, is 5.6%. So and if you have a STEMI, that goes up to 11.5%. But the 1 year mortality rate for somebody who has an opioid overdose, so let's say you respond to somebody, a 911 call, you give them Narcan, they wake up, you bring them to the emergency department, they go home, their 1 year mortality rate is 10%. So as high as a STEMI.
Wow.
So it highlights the fact that these people are at risk for death when they've had an overdose from an opioid, and then 20% of those patients, 20% of those patients that have been revived in the field come to an emergency department and then go home. If they're not intervened on and treated, 20% of those people will die within 1 month.
Wow.
That's just it's a shocking fact, but again, there is a good alternative, and there's something that we all can do to get these people on a road to some reasonable recovery. Okay, so Kevin, you mentioned this. So we have Leave Behind Narcan, which is a wonderful tool that not only users out in the field or people who have substance use disorder can have access to, but also having family members. So if you know that you have a family member who is in crisis or is using substances, having that person with Narcan available and can do the work to give it to them if they need it is life-saving. And the other piece to this is triage to alternate destination. So back to why we're here today, is that these are sobering centers. Not only are there a place for somebody who has a drug or alcohol problem to go to, but there are people within those sobering centers that are going to ask the tough questions. Right. They're going to say, hey, what did you use today? And hey, I've used methamphetamine, but maybe there might be some fentanyl or something else in there. When you stop using your methamphetamine, do you ever have withdrawal symptoms? Yeah. And to ask those questions and then to put them on a path where they're getting buprenorphine, which is our EMS treatment that we've recently rolled out here in Sacramento County, to give them a pathway forward where they can have ongoing care with buprenorphine.
For sure, and we also have, and some of us carry fentanyl test strips as well, where the individual can take a sample of the drug that they're typically using or what they bought. They can crush it up, put it in these small pouches, add a little bit of water, you dip a strip in, and it's kind of like a pregnancy test. It says, is fentanyl present or not? And the individuals that I know that our team has gone on and has worked with are shocked. They're like going, wow, there's fentanyl inside this stuff.
Absolutely. So one of the great things about buprenorphine and interventions is that when you look at somebody who has a substance use disorder and what their death rate is, so and then compare that versus just the general background death rate of our population, of our community, you can cut the risk of death in half by giving somebody buprenorphine and by getting them onto a pathway for medication-assisted treatment so that they get off of the substance. So it is a powerful intervention, and it's an intervention that we all need to be embracing in the field.
Right. And we will go into more of buprenorphine in the next module. We'll actually go through what it is and how it works and why it works, and so we'll get a little bit more.
Absolutely. So and there's some other data that I think is compelling as well, just to put out there, in that in patients who have been given buprenorphine, whether it's in the field from an EMS provider or in an emergency department, the 30-day retention, so how often are they to continue taking that medication, is staggeringly high. Yep. So if you were to revive somebody in the field with Narcan, bring them to an emergency department, no buprenorphine, no intervention, and they were just to be referred. So hey, here's some paperwork to go home with, go to see this clinic, they'll be able to help you. The number of people that actually go through that process is somewhere in the neighborhood of about 38%. If you were to do a brief intervention, meaning that there's somebody in the emergency department that's actually calling them out on their substance use and saying, hey, you should be trying to get some help, that only get a slight uptick in the number of people that go seek referral. But if you give somebody buprenorphine, the number of people that actually are retained within care is almost 80%. Mm-hmm. So it is just an enormous improvement in the number of people that stay in therapy and are really being saved from potential overdoses in the future.
Yeah. And the reason for that, and we'll get into this, is that buprenorphine actually partially is a partial agonist. Mm-hmm. And so it gives them that feeling, that physiologic drive that they're having that drives them toward using. And so they get that, but it's done in a very safe way, and the fact that they actually can't overdose on it either. And so again, we're going to get into that, but let's talk about how addiction works on the brain.
Sure. So just like any other thing, like if you're addicted to sweets, or
I saw Diet Coke on here, and
I was just about to say,
I just went there. I'm like, dang it!
How many Diet Cokes do I drink when I'm on ED shift?
Right.
But it's all of the things that we do that gives us some kind of joy or pleasure. That is going to stimulate a chemical pathway in the brain. So you have release of dopamine and other kind of reward circuit chemicals, which keep you wanting to come back for the thing again. Mm-hmm. And that's why we say at the start of the presentation here is that addiction is a medical disease. Mm-hmm. There is a medical basis for why people want to go back to that thing. Yeah. So and again, so kind of looking at it through that lens and just focusing there kind of starts to dispel some of that stigma and dispel some of those myths around use, and that it's just you're making bad choices, or you just can't control yourself.
Yeah. Yeah. And a lot of it probably starts in some realm of answering a real physiologic drive or need, mm-hmm. like pain relief or something that is helping you deal with or cope with an ongoing problem.
Sure.
But then it starts to kind of get away from you a little bit, and that relief from that temporary thing of pain or psychological trauma then becomes a physiologic need to actually have that substance in your body all the time, because you know that when you're dealing with the pain, it's far more difficult than when you have the substance in your body, and mm-hmm. that's where the switch happens, mm-hmm. and that's where the addiction starts to come in.
Well, and then when you start to stop, or you try to step back from that substance use, that's when withdrawal symptoms begin. Yeah. And the general description is people are miserable when they have those withdrawal symptoms. So to be able to kind of weigh, am I going to be miserable, or am I just going to go back to the substance? That oftentimes, unfortunately, that's an easy choice for people.
Yeah.
Okay. So we have 3 stages of addiction. So the first one is just the simple binging and intoxication. So just like we talked about, you're using whatever substance it is, it's giving you a dopamine rush. It kind of gets you hooked and in a position where you want to go back to that particular substance. And then that leads on to dependence, where various areas of your brain kind of have more of an emotional response. You have a yearning for that use just to get you back into a better place in your mind. There's also a memory component to this. There's areas of your brain that deal with cravings that kind of come into play. And then there's also areas of your brain that'll be impacted that work with use, that are the seat of your motor function. So your ability to function on a motor level can be affected by your dependency on a substance.
Yeah, and then that gives way to, actually, like you said, withdrawal symptoms. You're actually physically sick from not actually having this substance. You feel miserable, your body aches, you're vomiting, you've got cramping, you're sweating. Like all of these things are real physical, and then you realize, I feel like terrible. And then your brain goes, well, what is it that makes you not feel this way? Oh, that's right, it's that stuff I use.
And that's what you're describing is dependency, the third phase, where you get into that place where you're preoccupied, you anticipate the use of the substance, and you're absolutely dependent upon its presence in order to function. So another thing I'd like to do is just to talk about the why. All right, so why are we doing triage to alternate destination? Why are we talking about getting patients treatment for their substance use disorder? So some more just shocking statistics and numbers. So again, back in 2022, the number of people 12 and over that were suffering from a substance use disorder that never got any kind of treatment, 40 million people. It's an incredible, and a larger number is almost 94% of patients that are suffering from a substance use disorder, all comers, all ages. 94% of them never get access to any form of treatment.
Oh my gosh.
So imagine the situation where if you had 94% of people who had heart disease or diabetes or asthma and they never got any kind of care. Just imagine what the health outcomes would be, and this needs to be thought of in exactly the same way. So one of the things about triage to alternate destination and our discussion about buprenorphine, and even if you don't give it in the field, but getting people to a sobering center where they have access to counselors and people who can get them on a pathway for care, you're going to bite into that 94%, which is a wonderful place to be.
Yeah.
Okay. Stigma. We continue to talk about stigma, and as a common theme throughout all of our discussions here. Stigma makes people less likely to seek care, and this has been, again, what we've heard again and again and again. So you've got people who are secretly using substances. I've seen this all the time. You've got people who are well dressed, they're business people, and they come in and their urine toxins are positive for methamphetamines or for cocaine or for other things, and in a way, that's kind of our stereotypes, is we're looking for specific types of people, but you never can tell. So some of the words that you hear on the street. So the person's a junkie, or they're a drunk, or using the dichotomous meaning of clean versus dirty. Those are all words that will kind of paint you with a brush that you're not approachable, and I'm not gonna open up to you about my substance use disorder. And then you may see them on a 911 call for shortness of breath, or for abdominal pain, or some withdrawal symptom that they might be having. And you have no idea that there could be a substance behind there which is causing it, and no idea that you have a treatment with you that could help that person. But it's just because if you're not approaching people in the right way, they may not open up to you.
And I think calling them a person too, right? A person who uses drugs, a person who uses alcohol, makes them a person. Right?
That's right.
They're no longer a label. They're a person with a medical condition that needs help as much as the person does who comes to our emergency department and says, I'm having chest pain, I'm having a heart attack.
That's absolutely right. Yeah. So we're going to move on and just kind of get into the nitty-gritty of talking about substance use disorder versus medical emergencies, and trying to make those decisions. So I think it's helpful for us to look at the three broad categories of substances, so we can understand some of the physiology, and we can understand kind of what to expect when you see somebody who's using methamphetamine or something else. So the first one, methamphetamine, kind of the prototypical stimulant that we run into on the street and in our emergency departments all the time. Cocaine, MDMA, bath salts, these are all stimulants or uppers.
Yeah, they're the uppers. Right.
The uppers that we see, versus the opposite side, so your depressants. So things like benzodiazepines or alcohol. Opiates would fall into this, or opioids would also fall into this category. And then you've got a third category, which is more your hallucinogens, so your LSD, your mushrooms and things like that.
Wasn't as much. You didn't see as much of the hallucinogens until I think just recently we're starting to see it starting to creep in a lot more.
Yeah, and I know that there are certainly some the kind of legalization movements across the country that have moved marijuana into legalization. There are certainly a movement amongst the hallucinogens to try to move in that direction too. Okay, and all of these substances, they have different effects on the chemistry of the brain, either raising or activating different neurotransmitters, which will then cause you to have the upper effect or the depressant effect.
And this is interesting, because it just makes me go back to our talk about depression, and we talked about SSRIs, selective serotonin reuptake inhibitors, and it's interesting because we talked about people who are depressed. Are typically down, have a depressed affect, and it's interesting that an SSRI actually creates stimulation.
Yeah.
So you get the opposite effect of what you're getting in depression. So all of this is just, it comes full circle. If you begin to understand kind of the mechanics of dopamine and serotonin and how it works you don't have to know the details. Don't worry, no one's going to get a medical school examination. But just understanding that, being able to piece all these things together, go, oh, well, that makes so much sense why that drug works.
Absolutely.
Or why this person's acting that way.
So let's focus in now on those stimulants. Okay, so try to talk about the symptoms that you can see in somebody who is intoxicated on a stimulant, and then also let's talk about some of the mimics. It's always important to know kind of other things that can cause somebody to be acting that way. So first off, your stimulants, what do they cause in your patient? So they're going to be overly alert. They could be agitated to the point where they're showing psychotic behaviors, and we've all seen those patients in the field. You're going to see a rapid heart rate, tachycardia. You're going to see somebody who's has a lot of anxiety. They may just seem to be euphoric, and that they're just overly happy and kind of that manic presentation. But then you can also see hallucinations. You can see delusions in our case presentation about the delusional parasitosis on the skin, where you're thinking that there's bugs and things crawling on there. So what are the mimics for stimulant use? So you've got mania, bipolar. So is this somebody who is in a manic phase of their bipolar depression, right? So the person that comes in, I just went to Las Vegas, I gambled away hundreds of thousands of dollars, I bought my Ferrari, in the manic phase of their illness. Is this somebody who has a delirium? In elderly populations, things like urinary tract infections and other reasons why people can be delirious. Could this person have some type of a cardiac dysrhythmia, which could be causing them to be acting the way they're acting? And then other things like just pure sepsis, infections that can really be you can be tricked into thinking that you're dealing with a substance, but there's actually a medical complaint in the background. Flip side of this coin is our depressants. So these are the people that show in, they're sleepy, they're difficult to arouse, they've got some slurred speech, the decreased level of awareness or consciousness. The mimics here could be, have they fallen? Did they hit their head? Is there trauma? Is there an underlying intracranial hemorrhage in there? Is this somebody who could have suffered a stroke?
Right.
Is this sepsis? Could they be metabolic syndrome like DKA, diabetic ketoacidosis, which is causing them to be down. Or again, your cardiac complaints can come in here. So is this somebody who has a heart rate of 30 and they're just not perfusing and can be showing that sign of depressant activity? So that, and then we go into that third category of substances. So these are your hallucinogens. LSD, mushrooms. So the symptomatology here is that the patient's having hallucinations. Oftentimes that'll be kind of with some euphoria, but I think you can also see, and I've seen this too, where those hallucinations aren't all that great, and the person's kind of fearful, maybe withdrawn. They're having a difficult time interacting with you because they're scared of you. Auditory hallucinations can also be present. It's not always just visual stuff that people are experiencing. Folks can become very, very agitated, and they can also have some physiologic manifestations of that use. So like your heart rate's being fast, sweaty, those types of things can happen too.
Right.
Okay, mimics here. So if you're somebody who's hallucinating, immediately I think too, is this somebody who has schizophrenia, schizoaffective disorder, things like that. And then there are other metabolic things like liver disease. People can become have an altered level of awareness if your ammonia levels are high and those sorts of things.
It's like a form of delirium again.
Right.
Just that more confusion.
Right. So, and what I think it's helpful to do at this point is just kind of transition over to talk about withdrawal, because I think withdrawal symptoms that patients who are calling 911 oftentimes are going to be in withdrawal. And to be able to pick those out of the bunch to say, hey, can I treat you with EMS buprenorphine, and where do you need to be? I think that's also important. So withdrawal occurs after a patient has developed, that was 3 phases that we talked about. So they've gone all the way to dependency. So they've been using for quite some time. They've had a change in their brain chemistry, and then you take away that substance, and then typically what the withdrawal symptoms are is the opposite. So if you're using a stimulant medication, your withdrawal oftentimes will be you go down. If you're using a depressant, your withdrawal will often be like that, the opposite effect. So, and the underlying thing here is that withdrawal symptoms, particularly from alcohol, can be life-threatening. So alcohol withdrawal, if you have any symptoms of alcohol withdrawal, that is potentially life-threatening, and that means emergency department.
100%. Yeah, withdrawal seizures are deadly.
That's right.
Yeah.
So versus the person who has opioid withdrawal, who they're having nausea, they're having belly pain, they might have some diarrhea, those types of symptoms, those are not life-threatening. Their patient's going to feel horrible, absolutely, but it is not life-threatening, and those are patients that are going to respond to treatment.
Yep.
Okay, but also the general rule of thumb for withdrawal management when you're out in the field, if there's any significant withdrawal or you're in any way worried about that patient, your default is
emergency department.
The ED.
Yeah,
right.
Absolutely. Yeah, any doubts, transport to the emergency department. And we know that, as a new program, there's going to be a lot of trepidation for sure. And it may take a while to get comfortable with some of the things that we're talking about here. And like, this is going to be thinking about a patient. Make no mistake, this is going to be thinking about a patient in a way different than you've ever thought about them before. Normally, I think for the standard emergency medicine, EMS, I'll get there. Yeah. Our standard EMS patient is it's a dichotomous decision. What is the most likely condition? Do I need to treat it and transport? Right? This one may be, what is the condition and where is the best place for them? Which is not a decision we've ever had to make in the past.
That's right.
So so it's okay. Remember, the emergency department is the safety net. You're there. I don't expect, I'm going to speak for our department, we don't expect perfection on this. We know there's going to be some patients that go to the emergency department that maybe could have gone to a TAD program. That's okay.
I actually think that in the early days of TAD, we're going to see more patients coming to the emergency department. That's because that's people's reflex. You've been doing that forever, and then what we want to see is just as people get more and more comfortable, that we start to see some of those easier ones shaved away and getting off ramped to the TAD sites.
Yeah.
Yeah. So I want to spend a minute talking about opioid withdrawal a little bit more, because we do have EMS buprenorphine, and I think to kind of highlight that ability to treat the patient is important. So opioid withdrawal, typically these are going to be patients that present with abdominal pain, nausea, vomiting, those types of things. There is a score that can be used to score somebody's withdrawal, and it's called the clinical opioid withdrawal score, or COWS measure. So when you hit a COWS score of greater than 7, so that'll be your evaluation of the patient. So looking at their pupils, are they kind of moving around? Are they anxious? Are they restless? Are they having body aches? Are they having nausea? Those symptoms of withdrawal. If you hit 7 or above, then this patient could be a candidate for buprenorphine. And then when these patients can be treated. Our pathway is that they should go to an emergency department, but you will run into these cases where the patient's going to be like, I feel better. I don't need to go. I don't want to go. And that's okay. And in that situation, there's leave behind information on where they can go get further care, further treatment, to continue them down the medication-assisted therapy pathway. And the other great thing about buprenorphine is that if you give that person buprenorphine and then they go and they use again, it is protective against overdose. So that's the amazing thing about buprenorphine, is that not only are you going to treat their overdose response, but it is also protective against overdose from another ingestion from whatever their substance of usual use is. So let's talk about alcohol withdrawal as well. So this one, again, focusing on the fact that this one can be life-threatening.
Life-threatening,
okay.
100%.
Generally, it's going to happen anywhere from 6 to 72 hours after the last dose. My experience is these are typically folks that are coming in a day or two after their last drink. When they start to have tremors, shakes, they're getting super anxious. You're going to find that their blood pressure is really high, their heart rate is really high. They may have nausea, vomiting, and ultimately they can have seizures, which is your true life threat when it comes to alcohol withdrawal. So you can classify this as severe withdrawal. Happens normally a couple of days out after their last drink. These are folks that are going to have visual hallucinations. They're going to be altered. They can have all of the manifestations that we just talked about, the tremor and everything else, and the vital signs that are very, very abnormal. And these are patients that these are emergency department, yep. Do not pass go. You're going to take these people to the ED to get the care that they need. Okay. So we also have our benzodiazepines, another depressant, on what the withdrawal is from this. I don't think this is quite as common as your alcohol or your opiate withdrawal, but there's certainly folks out there that use a lot of benzodiazepines for their anxiety disorders and things. These kind of fall into the same bucket as your alcohol withdrawal, in that they can be life-threatening, and essentially you're going to have many of the same symptoms as your alcohol withdrawal. So they can ultimately lead to seizure events, and these again would be patients that we would want to see them in the ED.
Yeah, for sure. And remember that these aren't someone who just got a prescription for this and it's on their first or second or third day, right? So when you've been on these medications long enough, it literally almost changes your compass to where your body is now reoriented to a new true north. Mm-hmm. And so when that drug is no longer there, it's the stimulation or overstimulation of some of these receptors that eventually degrade into a seizure.
That's right. So let's switch gears and talk less about the withdrawal, but the actual use and kind of what overdoses look like. Mm-hmm. So for depressants, I think this is kind of clear. You're going to have a decreased level of awareness, decreased level of consciousness. You may have some lowered heart rate from these ingestions. And the biggest thing, and this is why people die, is the respiratory depression that comes along with opioid overdose. Fentanyl being as strong as it is, being just that you could kill dozens of people with the amount that would fit on the head of a pencil. Mm-hmm. And the respiratory depression is what does it. So people oftentimes, they get lower level of awareness, they may fall asleep, and then their respiratory drive drops and they die.
Right.
All right. So treatment here, so obviously naloxone in the field, airway protection as necessary, and then transport to an emergency department. We talked about Narcan. Our Narcan leave behind kits are out there. Just the uptake of that program in our county has just been remarkable. So not only is it fire-based EMS, our private providers are giving Narcan out in the field. We've got our police, law enforcement are doing it.
Yeah.
All of our emergency departments have this, and people walk into our emergency department and you can get a box of it. So it is out there on the street, and I think it's helpful in preventing overdose deaths. That's the nuts and bolts of substance use disorder, looking at alcohol use, looking at other substances. We're going to go and talk about a case in a couple of minutes here.
It's a lot to take in. This is a lot to take in. And these videos are here to watch again if you need to, and also to ask questions.
Absolutely. So we'll see you with the case. All right, so we're back, and we're going to talk about a pre-hospital case for our substance use module. So this one is a 43-year-old who had a history of a seizure disorder. So presented called into 911. He had his friends witness him have a seizure in front of them. They're not sure what medicines he's on when EMS arrives at the door, and
that never happens.
And yeah, right. Friends are just there, just having fun, and they don't know anything about your medical history. But they do say that it happened 15 minutes prior to the arrival of the EMS crew, and then as the medics arrive and they start doing their management, they see that. The guy looks like he's post-ictal, so like the usual kind of not completely obtunded or out with a GCS of 3, but kind of GCS is in the 10 range. He's maybe kind of not so cooperative with your assessment, and just seems like he might be coming out of one of his normal seizures.
It's like a standard
one
post-ictal case.
But then while they're examining this guy and they move him, there's this little white rock that rolls out onto the floor. It's about the size of a marble, and it's just that looks just a little bit funny. So they end up kind of finishing their exam on this patient. This patient's he's tachycardic, his heart rate's 120. He has a GCS, they give him a GCS of 11. They find that his blood pressure is 190 over 120.
Wow.
He's breathing a little bit fast. He's around 20 breaths per minute, and his O2 sat's holding around 96%. So what do you think at that point when you hear that kind of a patient? Do you think
that's not your standard post-ictal patient? Right, wildly hypertensive, tachycardic. The GCS goes with it. I'll give you that. I would have probably looked for other things like, is he incontinent, is there tongue biting, things like that. But we have a patient with a history of seizures that had a seizure until I get to the stuff I can measure. And that's probably a good clinical tip, is when you can't trust your subjective stuff, the things that is getting told to you, trust your objective stuff.
Right.
The things you can measure.
Right.
Temperatures, vital signs are incredibly reliable. But I would say in a person that's post-ictal that is not currently seizing, that blood pressure is probably abnormally high.
Yeah. So just when you think about triage to alternate destination, you think about, is this person somebody that could go to a sobering center? Is this somebody that would go to a mental health facility? Your primary impression right now is not behavioral crisis.
No, I'm thinking ER on this guy all the way.
All the way.
Especially because he's still pretty profoundly altered, so he'd probably exclude himself right there.
Exactly.
Right, his GCS is 11, he's too low.
Less than
to go to
14?
either one of these. He's less than 14, and his blood pressure is above 180.
Yep. He's outside of the safety margins that have been set for triage to alternate destination. So yeah, this guy goes to the emergency department, and what do they find, do you think? They put him immediately through the CT scanner, and he's
not waking up.
Because he's not waking up,
Yeah.
and he's got a large intracranial hemorrhage. So that little rock that they found, he gets a urine drug screen during his emergency department workup, finds amphetamines in there. So the working diagnosis is that he's got what's called a subarachnoid hemorrhage, and it's likely from amphetamine use. So gentlemen that had a history of seizures kind of can take you down a pathway to think, well, maybe this is just a seizure disorder. But clearly there was something else in the background that got this guy.
Yeah, be a good detective. Be a really good detective. Don't just believe. It's like trust but verify.
Right.
Right, yeah. I know the guy's got a history of seizures, but until you see the incontinence, the tongue biting, and maybe a little tachycardia, but relatively normal vitals and not hyperthermic, okay, then you can go, okay, this guy's probably post-ictal. But if you get this guy, and he's still wildly hypertensive and tachycardic, and he's altered, but his seizures stopped, I'd be thinking, now there's something else going on here.
Right. So it brings us to a conversation about what are our pitfalls. So common pitfalls to watch out for when you're thinking about, is this somebody that could go to an alternate destination site? So one, is there an overdose that needs observation? So they've received Narcan. Right.
Yeah.
So that's somebody that could slide back down into a lower GCS, respiratory rate could drop. So somebody who's received Narcan probably needs to be seen in the emergency department. Any unstable vital signs. So just like we talked about, our kind of guardrails around what a stable patient looks like, your 50-50 waiting room criteria. Those, if you're outside of those vital signs, that should be a red flag to you. They're unable to consent. So somebody GCS is so low that they can't talk to you. They don't have the ability or capacity for choice. Those are red flags and places where you could really step in it.
Yeah, and I think the consent part is important because we haven't talked about this yet. So we're getting into the policies in Module 6,
right,
which is next. But we're not, like, these are not patients where we're like going to go, well, I got a better place for you, we're going. Right. These patients for this program are going to need to consent.
Right. For sobering, these are voluntary. Take me to a sobering center. I prefer to go there. Yep, that's right. The other thing is we talked about non-ambulatory, so that's always a red flag for when you're thinking about triage to alternate destination. You've got to be able to get up and move around and walk on your own. Always be assessing these patients for trauma. Be assessing, did they fall? Did they hit their head? Any of those things, and then always consider that there could be medical mimics that could be working in the background. So we've got some inclusion criteria here that we're going to cover during Module 6. Yeah, I think that'll be a great place for us to go over our parameters for who is a candidate for triage to alternate destination. And I think that the bottom line here is that when you look at a patient, you could think of the Goldilocks, and your porridge is too hot, it's too cold, or it's just right. If your patient is too hot or too cold, there's a middle ground where they're just right. And that's where we want to be, make sure that everybody's safe and effectively taken care of.
It's very interesting, this Goldilocks thing, because in Stanislaus County for our program, we found exactly that. 1/3 of them needed to go to the emergency department, 1/3 of them could have gone to a psychiatric center, and 1/3 of them fell out for some other reason. And so it is about a third, and a third.
That's right. That's right. So that's it for Module 5, and we're going to move forward with Module 6, which is our policy discussion, right after this.